Welcome to the Understanding Healthcare with Zack podcast. Today I have with me my guest, Dr. Eric Bricker, who's an internal medicine physician and chief medical officer at AHealthcareZ. He runs this popular AHealthcareZ YouTube channel, which I'm sure many of you have watched and listened to as we have at Stedi. Part of our onboarding materials included a bunch of Dr. Bricker's various YouTube videos. So we're very happy to have you on the show. Welcome.
Thank you so much, Zach, and thank you for using the videos. It's exactly what they're for.
What was the first video you filmed and why did you do it?
Oh man, of course it was terrible. So, we actually started using video at my startup, Compass Professional Health Services. Yeah, I'm gonna say it was like 2010 or 2011, and we used it internally, and then we started doing some external stuff. And as you can imagine, me on video was just terrible. And so then after we sold Compass and I was then free to kind of shoot people straight in terms of the inner workings of healthcare finance, that's where I started the A Healthcare Z video channel on YouTube, and then I post them on LinkedIn as well. And it's just iteration, right? I've literally done 500 of these. And so the original ones were horrible, and I've slowly gotten better over time.
Well, love it. And is there any particular focus to the videos or theme? Like, have you? It seems like you've covered a whole bunch of different things. How do you know what to talk about next?
Yeah, it's healthcare finance, so it's the money flow. So, the money flow in healthcare, at the end of the day, it's super complicated. I've come to admit that. A lot of people are like, it makes no sense, it's confusing, and of course, I'm like, "Look, it makes complete sense to me," but I literally think about this all day, every day. So I can see how for other people, it would be ridiculously confusing, so I'm just trying to, in very small increments, educate folks about it.
Very helpful. Well, for someone coming into healthcare, maybe you have a tech founder who's coming in from a different industry. Maybe they're coming from fintech or something like that, and they're moving into healthcare. I think that there's it's a hard time, a steep ramp for people to get oriented.
Yeah.
Even the beginning when people talk about, oh, the clinical side of healthcare versus the administrative side of healthcare. And you're talking about the funds flow. Can you draw some of those distinctions for us in terms of when someone says the clinical side, what do they mean? As opposed to talking about the administrative side of healthcare, and how would you subdivide it from there?
Yeah, so I am I'm a physician. I went to medical school at the University of Illinois, and I did my residency in internal medicine at Johns Hopkins in Baltimore. And so by clinical, that means everything related to patient care. And it could be on the services side, so it could be like an actual doctor or nurse actually seeing a patient. But then there's obviously like imaging and lab and medical devices and pharmaceuticals, et cetera, that are all also quote unquote related to patient care. But of course, all that, we do not live in a centrally planned command economy, right? We work in an economy that uses money, and so the entire money side is kind of, whether it's intentionally hidden or just it's just incredibly complicated or whatever. For the vast majority of people who are involved in patient care, they have no clue how the money flows.
Super helpful. So, you're kind of saying that there's the clinical side, which is how the care is delivered and how the patient is ultimately cared for, or whatever it is, if it's a lab being drawn or an inpatient visit or procedure or something like that. And then the financial side is just because the whole thing has to be paid for somehow, how things work on that front and how the funds actually flow. When when you look at the intersection of those two things, at what point does it transition from clinical to the financial flow, and where
Yep.
are some of those things? And I know you've done some great videos on this. At what point is the crossover from handover from the clinical side, and how does that work? What are some of those decisions that are made?
Yeah, so it's a great question. And really, everybody's kind of familiar with like the triple aim or the quadruple aim, where in medicine you're trying to provide high clinical quality. You're trying to provide access to be able to have access to the medication or for the physician, because obviously quality doesn't matter if you can't even be seen, right? So number two is access. Number three then is cost, which is almost a proxy for access, right? Because if you can't afford it, then you can't access it as well. So that's the kind of the financing piece. And then the last piece is sort of workforce sustainability, because there's these issues of burnout within people who do patient care, then okay, so fine. So all four of those things are not siloed, they're interrelated. And so specifically, how does the money, how does the finances impact the clinical care? How does it impact the access? Obviously, it impacts is the cost. And then how does it impact the issues of sustainability in terms of burnout for employees? And that's where the money flow, because it's complicated and it's hidden, it's kind of like gravity. Like you can't see it, but it has tremendous impacts on what you do in terms of like how long are your visits? Why are doctor visits only 8 to 15 minutes long? It kind of has to do with the money, right? Why is it that physicians are even feeling burnout? Well, it might have to do with kind of the patient staffing ratio for like the nurses, where a night nurse has to take care of like 8 to 10 patients at night. Well, why does a nurse have to take care of 8 to 10 patients at night? Well, it's kind of because of the money, right? So I won't give you any more examples, but you get the idea.
Very helpful at a high level. When we think about it, zoom in and maybe we can walk through. I go into, or someone goes into a doctor's office for a simple office visit, like the strep test, for example. Could you walk us through, what happens in terms of the funds flow
Right.
and maybe starting with the clinical side, and at what point is a claim issued, and questions of coding and things like that. Could you just walk us through what it looks like for a $100 visit to get billed?
Yeah. So this is this so it's a fantastic question. And this is where, even with a very simple question like the one you just asked, the answer is exceedingly complicated. And so I think in terms of healthcare finance, I think it's very helpful to break it down into buckets. And you can think of it in terms of like there's four buckets. Okay. There's the Medicare bucket, there's the Medicaid bucket, there is the what I'm going to call employer sponsored insurance bucket. And then the fourth bucket is ACA plans or Obamacare plans. So those are the four different sources of funding for that visit that you described. Now, of course, because it's complicated, every bucket has to have sub buckets. So within Medicare, you've got two sub buckets. You've got traditional Medicare and you've got Medicare Advantage. And then within Medicaid, you also have two sub buckets where you have fee for service Medicaid, which is analogous to traditional Medicare. And then you have Medicaid managed care, which is analogous to Medicare Advantage. And then, Medicare is for folks that are over 65 or if you're permanently disabled. And then Medicaid is run by the states and it's for low income individuals and families. And every state has a different rule in terms of how they define that. Okay, fine. And then you have employer sponsored insurance, which also has two buckets. This is where the majority of people in America, it's like 60% of Americans, get their insurance through their job or through their employment or through their spouse's employment. And there, the two sub buckets of employer sponsored insurance are fully insured and self funded. And then finally, there's ACA plans, right? So ACA plans doesn't have any sub buckets. Okay. So that gives you a total of seven, right? Two for each of those three, and then the ACA. It's super important to understand volume. Okay. So the volume of claims and the volume of visits and the volume of care in America is primarily driven by seniors. Okay. So I just said that 60% of Americans get their insurance through their job. So you say, oh, so the majority is employer sponsored insurance, right? No, absolutely not. Why? Because the number one defi- risk factor for needing medical care is just age, right? No man or woman stops the movement of time. And so as we get older, we just require a lot more health care. And so while Medicare only covers like, it's like 25%, maybe even like 20% of all Americans, I shouldn't say the vast majority, but the majority of care is actually provided to seniors on Medicare, right? And then there's been a big change where it used to be that the vast majority of folks were on traditional Medicare and very few were on Medicare Advantage. And Medicare Advantage has grown significantly. So now it's about 50-50. So about half the people on Medicare are on traditional Medicare, and about half the people that are on Medicare are on Medicare Advantage. So just know for all of that care. So like if you ever walk into a doctor's office or a hospital lobby, what are you going to see? Old people. I'm not trying to be pejorative, but like that's who gets care, right? And it's actually projected in about 10, 15 years that upwards of 70 to 75% of seniors are going to be on Medicare Advantage, not traditional Medicare. So Medicare Advantage is becoming the 800-pound gorilla of payment in America, right? So when we talk about all these categories, it's super important to understand Medicare and Medicare Advantage.
Let me jump in with a quick question. My naive take about where you might go first here would be that the first thing that the doctor probably needs to figure out, the physician's office, is what bucket you fall into.
That's right. First question you ask when you call up to me, hey, I'm Eric. I'd like to make an appointment with Dr. Jones. First question, what kind of insurance do you have? That's exactly right.
Great. And then if I say Cigna, they need to know probably a great a great deal more information there in terms of figuring out, am I Medicare Advantage? Is it a traditional? Do I have a TPA that uses Cigna as a rented
Oh,
network?
yeah. That's right. So, and then these insurance companies all do some combination of those 7 that I just described. So if you just say Cigna or Blue Cross or United or whoever you have, right? It could be Cigna Medicare Advantage. It could be Cigna Medicaid managed care. It could be Cigna fully insured. It could be Cigna self-funded, or it could be Cigna ACA plan. So even though you said you had, and of course, the vast majority of people are like, I have no idea what kind of Cigna I have. I just have Cigna. And so that's where the insurance company needs the group number and the member ID to then figure out which one of those 5 in that particular instance you're on.
Super helpful. And that, can you, I don't know how deeply you know the insurance eligibility check workflow and what happens behind the scenes there, but if you're familiar with the real-time eligibility check, can you walk us through what that is?
Yeah. So what happens at the doctor's office or at the hospital is that and so healthcare in many ways in America, you got to understand it has these very large sort of corporate entities like large hospital systems or large physician groups. Like in California, you've got the Kaiser Permanente, or it might be the Cleveland Clinic or Mayo, et cetera, et cetera. But then you also have basically a cottage industry. It's a lot of mom and pop shops, right? It's a lot of, I mean, it's a smaller amount, but it's still like 30 to 40% of physician practices are like solo docs or 2 to 3 docs or whatever. And so whether it's the small shingle hanging physician practice or the large corporation, they're going out to these centralized clearinghouses of eligibility information. That, believe it or not, I actually started in revenue cycle consulting back in the 90s, and these clearinghouses didn't exist. You literally had to go to if you said Cigna, you had to go to Cigna and actually figure out what kind of Cigna they have. But now they've centralized it into a quote unquote clearinghouse, of which Stedi is able to access that information and then pull that off to be able to verify, because there's all sorts of reasons why what they say is totally incorrect. Probably the most common reason is it's expired for whatever reason. You didn't pay your premium, you changed your job. There's even insurance card theft where you're like, oh yeah, this is it's like having a fake driver's license. They absolutely, people have like fake insurance cards, et cetera. So the verification process is super important. And I'll just say one last thing, because we could talk about an hour on each one of these topics, is that healthcare is known for having high turnover in the front office staff. So those people that are collecting that eligibility information, I'm not trying to blame them at all, but oftentimes they're very undertrained because they're very new. And so nobody actually showed them how to use the eligibility software. And so the person just goes and they have their visit and they just take in the information on the insurance card and they don't verify it. And so then that's when the doctor or the hospital bills, it's not the correct insurance. It gets punted back to, denied to the physician or the hospital. And then all of the billing systems are automatically set up to, as soon as they get a denial from the insurance company, they just automatically bill the patient. And so that's where people are like, but I have insurance. And like, well, why did I get this bill? And it's like, look, your insurance was denied. And so anyway, so oftentimes it's not even, sometimes it's a technology problem, but oftentimes it's a front office staff training problem that starts with a lot of the confusion.
You hit the nail on the head, and the reason for this, interesting, you kind of perfectly nailed the history there of back in the 90s. Probably all the way through the 90s, you had to go out to the individual insurance companies, and
Right.
what changed there was
By phone, by the way, by
by phone.
phone.
Yeah, yeah,
It
yeah.
wasn't even on the internet.
And what what changed there was HIPAA, which most people know as a privacy compliance framework where you go into your doctor's office or your hospital and you're always signing a HIPAA release form. And if you're a software provider, you know that HIPAA means that you have to sign a BAA probably, and you have to have these security controls in place. But HIPAA also created something called administrative simplification rules, which stated that all of the payers and all the providers had to use a standardized format for claims and claim status and the ERA, which is the remittance advice that comes back, and of course the eligibility check. And so what that meant in practice was that whereas before you had to go to all the different payers over phone, over fax, over the internet, if in some cases, and deal with a different format. In this case, you could use this underlying X12 format, which is a bit complicated to work with and not something that modern developers would be excited about. But with an NPI, first name, last name, date of birth, and member ID and the payer ID, you could get the insurance eligibility for virtually any patient in the country.
Yeah, and it's super helpful. Back in the old days, literally people used to wait on hold with the insurance company, like all day long. That was their job, was to wait on hold to check eligibility.
Well, it's funny because that's actually how a lot of it still works today. So what'll generally
Right.
happen is that people take a first shot at this and say, okay, I'm gonna try this for Joe Smith, and who I'm looking at his Cigna card right now, and they'll make an attempt, and it'll say member not found via the programmatic eligibility check, and of course, it's probably because his name is Joseph, not Joe. But the front office staff, to your point, hasn't been trained to go and do those additional follow up checks. And so what happens is they pick up the phone and they make a phone call. Now the practice starts making, or large provider group or health system starts making thousands or tens of thousands of phone calls a month, and now they hire these AI dialers to help with that. And of course, on the other side, the payers are receiving hundreds of thousands of phone calls a month, and so they need AI agents in order to answer these voice agent eligibility checks, and it becomes a whole bunch of complexity due to some of these technology problems that many people are working on. Stedi and a lot of our customers are working on solving. Anyways,
Yeah,
let's get back
that's
to
great. Yeah.
your story here, and you can pick back up where you left off.
Okay. Yeah. So you've got the traditional Medicare folks, and so if a person comes in, they actually have traditional Medicare. They're going to have a card, and so there, interestingly, Medicare does not actually process their own claims. So when a doctor or a hospital submits a claim for a person with Medicare fee for service, they don't actually send it to Medicare. They send it to a private company that's called a MAC, a Medicare Administrative Contractor. And there's one's called Navitus and another one's called Meridian. We don't have to get into it, but they've essentially geographically carved up the country. And if you are in this particular part of the country, then the way that the doc or the hospital gets billed is actually by billing the MAC. And then the MAC essentially takes the money from CMS, from the government, from the Department of Health and Human Services. So it's ultimately the government that's paying in that traditional Medicare sense, Medicare fee for service. And the only thing you have to do is perform the service and submit a bill, and you get paid. There is no, there are very, 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 very few prior authorizations in traditional Medicare. People are like, oh, but believe me, like the type of prior authorizations that they have are on stuff that's like rarely done. It's like, so the point is that you never get denied for prior authorization with traditional Medicare. If the orthopedic surgeon wants to do a hip replacement, they can do a hip replacement. There's nothing stopping them from getting paid for doing a hip replacement with traditional Medicare. Now, when you move over to Medicare Advantage, which originally started during the Bill Clinton administration, and it was super small back then, but it has since grown. And this is where the government pays monthly capitated premiums to private health insurance companies like Blue Cross United. Cigna actually just got rid of theirs, so we can't say Cigna anymore. Blue Cross United, Aetna, Kaiser. There's a whole bunch of like hospital-run Medicare Advantage plans as well. And so they'll give them like $1,000 a month or $1,200 a month, and it's essentially capitated.
Can you talk us through what capitated means?
Yeah, it's a fixed amount of money to pay for all of their medical and pharmacy expenses, and you don't get any more. So let's just say there's a fictitious insurance company that has Eric and Zack as the two members. Now, they're going to get $1,000 a month for me, and they're going to get $1,200 a month for you. And with that $2,200, that's going to the insurance company. And then this insurance company is then I go to the doc, they send a bill to the insurance company. You go to the doc, they send a bill to the insurance company. And they got to take that money out of that $2,200. And if there's more bills from the docs for you and me than the $2,200, they have to take it from other Medicare Advantage people who are like totally healthy, right? There's like 66-year-olds that are like marathoners and never go to the doctor, right? And so what they're doing is they're pooling all of those payments from the government, and they're required to pay 85% of all of those premiums out to doctors and hospitals for their care. But there's no limit on the other side. So if for some reason there's more than 100% of that premium that's charged in bills, then the insurance company has to eat it. They've got to pay for it. I'll just briefly say that has been growing because it's actually oftentimes less expensive for an individual to be on a Medicare Advantage plan, and you get free dental and you get free hearing aids and you get free vision. So they give you all these perks. And so that's why now the big difference between traditional Medicare and Medicare Advantage is that Medicare Advantage, though, does have prior authorizations. And so in terms of payment, there's a lot of denials to doctors and hospitals for Medicare Advantage claims because they did not obtain prior authorization. So the denial rate is just much higher for Medicare Advantage claims than it is for traditional Medicare, which is why some hospitals and doctors, they drop Medicare Advantage plans. Like last year, oh, I took this Blue Cross Medicare Advantage plan. Next year, I'm not going to take it anymore. And it's a free country. They have the ability to do that.
So it sounds like you're saying that amongst these that, well, aside from the self-pay bucket, which we haven't talked about, but that I would think that based on your framework, Medicare claims, not Medicare Advantage claims, are among the easiest for doctors to process.
Pay super fast. That's right. That's right. In terms of the easiest of all the buckets, they are the easiest. Traditional Medicare is the easiest of all of them. The downside of it is that the government sets the prices. There is no quote unquote negotiating with the government in terms of how much they pay for a hip replacement. The government's like, yeah, we're going to pay you about $5,500, and you're going to like it, and you're going to take it. And so while they get paid fast, they don't get paid very much. And then Medicare Advantage, by the way, they also pay about the same as Medicare. There actually is negotiation by the Medicare Advantage plans with the docs and the hospitals, but usually that negotiation comes out around what traditional Medicare is. So the docs and hospitals end up losing out with Medicare Advantage because it pays about the same as traditional Medicare, but they get a lot more denials because of the prior authorizations.
Maybe you could talk about, because we had this eligibility check, and you can tell now that I'm a Medicare Advantage patient, and I have the appointment for the strep test, and
Yep.
it sounds like there's going to be some clinical notes written up and things like that. Can you walk us through what's the nuts and bolts in the EHR of what happens? That I'm in with the doctor. The doctor's taking notes or talking to a scribe. What happens in order for that claim to actually get sent to the MAC or to the Medicare Advantage plan?
In healthcare, there are two separate bills for what are called the professional fees for the actual doctor or the physical therapist or the occupational therapist versus the facility fees for the location where you are, which would be like the ambulatory surgery center or the imaging center or the hospital itself. And so the professional fees go on a bill it used to be called a HCFA 1500. Now it's called a CMS 1500. And then the facility fees go on what's referred to as a UB04, and UB stands for Universal Bill, and it's the 2004 version of that bill. And so to your point, all of that clinical documentation of strep throat came back positive, strep throat came back negative, patient complains of sore throat, those all get translated into codes on those bills. And there's some large classifications of codes that everybody in healthcare needs to know. And every bill needs to have a diagnosis code. And oh, by the way, the diagnosis code could just be a symptom. Like you can have a diagnosis of quote unquote sore throat, right? Because you don't know if you have strep throat or not. And so there you can actually code the claim as just sore throat or abdominal pain or headache, right? That's not a quote unquote disease, but you can just code a symptom. Or if you're totally healthy and you're going in for your quote unquote annual physical, like you can have a code for just, annual physical, right? So you have to have a code. Those are called ICD-10 codes International Classification of Diseases, the 10th revision. We started using those in 2015 in America. Before that, we used ICD-9 since the 1970s. So we actually had a major update about 10 years ago. And there's like over 60,000 codes. There's gazillions of codes. They're anywhere from 4 to 7 digits. They're typically 3 digits and then a dot, and then 4 more digits. That's a combination of numbers and letters. So a lot of times you'll see these codes and it's like, I don't even know if that's an ICD-9, or I don't even know if that's an ICD-10 code or not. It's like, well, if it has a dot in it, it's probably an ICD-10 code. Okay. The next, what did you do about the
And
actual sore
what is
throat?
that step called? Maybe give us a preview of the process here. So that step is called coding. Uh,
Yeah.
and what are the remaining steps that we have after you've got the encounter that happens, and you know you got your notes, and then you've got coding.
Okay. Um, well, I just want to say one more thing about coding is that what I just said was just like actually the tip of the spear about coding. There's a lot more to it. So like what did you actually do? So that's the procedure code. That's referred to as the CPT code, current procedural terminology. And that's where you might have an office visit. So there's literally a procedure code for the office visit itself. And then there's a procedure code for the actual strep test. Okay. And let's just make it simple. Let's just leave it at that. It's important to know that in a pre-AI world, people literally needed to do the coding. And when it came to very complex coding for things like coronary artery bypass grafts, that heart bypass surgery in the hospital, you had this chart that was that thick with paper, or like pages and pages long within the electronic medical record. And there was literally a person who was reading through that and translating those human created notes into those codes. And just know that that process is so complicated that even at major hospital systems with like tens of thousands of employees and like 8 to 10 hospitals within the system, the number of people within that hospital system who actually understood how to correctly code, you could count on one hand. Okay, so it was analogous to that receptionist problem at the hospital. The vast majority of the people who were doing the coding were actually not sufficiently trained on how to do the coding. They largely were guessing. Okay, and again, I'm not trying to be pejorative, but just know that even if you did everything right with the prior authorization and you did everything right with the electronic submission, blah, 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 it could still get denied because the coding was done incorrectly.
When people talk about upcoding and things like that, there's the problem of you want to there's a blurry line between saying we want to code for the correct procedure
Okay.
or diagnosis, but also if I'm line between that and nudging the doctor or the coder to say, hey, did you do a strep test, or did you really do something that's a little bit more than that, and saying because you can make more money. And when you see these lawsuits or criminal cases where, particularly against Medicare, where people have encouraged upcoding, it's a huge problem.
It is, and the entire process of quote unquote coding accurately everything's got to have a fancy name. So it's called CDI. It's called clinical documentation integrity, right? Because integrity sounds good, but integrity on the part of what the doc and the hospital see, on the part of the payer, whether it's the government or employers or the insurance carrier, they would call that upcoding. So that same process, depending upon how you look at it. Some call it CDI, other folks call it upcoding. So it's just like a bill at a restaurant, right? And so you've got, French fries, hamburger, like all that sort of stuff on there. Those are the codes. But of course, the bill also has the dollar amounts, right? So the pricing that's on there. And that pricing for whether it be a physician's office or an ambulatory surgery center or a hospital, that comes from something that's called the charge master, where they're actually doing, and it has all these things have processes, and it's called charge capture, where they're basically adding up the person's time, and they're adding up all of the supplies that are used. They're adding up all the things that are done, and then they're putting dollar amounts next to or at the and all those dollar amounts add up. How they add up, it has these things called, just know that these things called revenue codes, and those revenue codes then add up to then the final bill at the bottom, which could be like $84 or $110 or $450,000. Right? So there's an actual dollar amount on that bill. That bill, when it gets, that dollar amount is not the dollar amount that the doc or the hospital gets paid. Okay, those are referred to as billed charges. The doc and the hospital and the insurance company, or et cetera, they have pre-negotiated a contract that stipulates what the payment amount will be separate from those billed charges. That payment amount back is referred to as the allowed amount. So when people talk about the quote unquote price of healthcare, just know that the billed charges from the doc or the hospital is never the actual cost of healthcare. Okay. What something actually costs is referred to the allowed amount, which is the actual quote unquote amount of money that actually then gets paid back to the doc or the hospital for those particular services because they have contractually agreed to that allowed amount. Now, some of you, probably the best example of this is I'm sure many of you have had your blood drawn and you get labs and you'll get a bill from the lab and you'll see, or an EOB, and you'll see it says there, blood test, and it'll say $375. And then it will say insurance paid $4. And then it'll say the difference between the two, the $371, was written off. And that's because that was the contractual agreement between the lab company and the insurance company, that for this particular lab, you can bill whatever you want. You can bill $1,000 if you want to, but we're only going to pay you 4. That's the allowed amount.
And there's some funny dynamics here where you would think it's okay. It's quite easy that if I'm going to be sending labs on a regular basis, I know I'm going to get paid $4 for this. So I would just put on the claim, on the invoice, effectively $4. Well, turns out that the provider contracts are actually very complicated, and so they're very hard to interpret, and they're not machine readable. So you can't go through a contract and say it's not as simple as you plug into a programmatic contract. Here's the CPT code, the procedure code, and here's how much I'm going to get paid. You have to go and figure out those formulas yourself, and the way you calculate those formulas might be different from the way that the payer, the insurance company, calculates those formulas. And so you would think that people put their actual calculated amount, what they believe that they're going to get paid, as the amount on the claim. But there's a funny dynamic here where if they put $3.99 and they might have gotten paid $4.30 for it, then the insurance company may just pay $3.99 instead of $4.30. And so what happens is, in at least some cases, or in certain scenarios, the provider will send through the claim with the sticker price on it. So the $1,000, and then when the payment comes in along with the electronic remittance advice, which is the electronic version of the EOB, that the patient gets the EOB thing that says, this is not a bill on the top of it. The provider gets an ERA that has a list of what was paid. It says, you billed us $1,000. We paid you $4. And then this write-off that you're talking about is how they do the accounting for that. So and there's different decisions that are made. This from the revenue cycle management space of does the provider's system, is it configured such that they're writing off $996 on each one of those claims, or are they doing it in some other fashion?
That's right. And also, and to your point, so there is a technical term for what you just described, and that is referred to as repricing. So if you're working in this space, that whole process of taking the billed charges and translating it into the allowed amount is referred to as repricing. And that is also a very error-prone process where the carrier might reprice it incorrectly. And so the hospital or the doctor might be being paid incorrectly, but the contracts are so complicated that the doctor or the hospital doesn't even know that they're being paid incorrectly. And so they themselves have not done a good job of keeping track of, with obviously with software or with people on their end, that when they do get paid, are they actually being paid according to the terms of the contract?
You kind of go from the spectrum of unsophisticated revenue cycle management process to extremely sophisticated. And at the unsophisticated end, you just put the sticker price, and whatever the carrier pays you, you're marking as, this is what I got paid. The rest of it you're writing off. And then as you get more sophisticated, you're doing these things like, you're checking the repricing on your side to make sure that if you may still send $1,000, but then if they send you $3.50, you say, that's not what it was supposed to be.
And I will tell you that this entire conversation that we're having has systemic ramifications in that the process is so complicated and it's cumbersome and it's very expensive just to go through this process, that that's one of the reasons why so many physician practices have sold their practice to a large hospital system or to a private equity firm or what have you, because they, as a small practice, were incapable of successfully navigating what you and I have been talking about for the past 30 minutes. And so it is, so you're like, but I liked Dr. Jones when he wasn't part of the large XYZ hospital system. Now there's all these rules and the bureaucracy, and I got to go through central scheduling, and I didn't have to do that before. Why is that? This exact conversation that we're having is exactly why that had to happen.
Do you see that as something that there's promise of that changing now? Like, do you see there's a huge number of startups being started to fix some of these problems? Now, I know that there's a little bit of a paradox there, in that many of the startups are going after the private equity backed space because there's a distribution advantage there. They land one,
Right.
private equity group, and then they're getting through all of the physician groups, all the practices that are rolled up there, versus having to go through a small practice by small practice. But do you think that do you see glimmers of a hope that some of these tools, AI and such, may make it more feasible for improve the quality of life for physicians?
Oh, yeah, 100%. So a lot of these physicians now can, remain independent, or their group can remain independent, and a lot of times, unfortunately, a lot of the independent physician electronic, medical record system also automatically incorporated the billing to it as well, and that I'm not gonna name any names, but that combined electronic health record/billing company was charging physician practices through the roof. It was exorbitantly expensive. And then if you wanted, let's say you wanted to change EHRs, but you didn't want to change your billing, you couldn't do it because the two were tied together. Or if you wanted to keep your EHR, but you wanted to change your billing, you couldn't do it because so now you have some modular choices. So now if you like your EHR and you don't want to change your EHR, it's not tied to your billing company because you've got one of these new startup organizations that actually can effectively do billing on your behalf. And then the last thing I'll say about this is that unfortunately, the billing was so labor intensive that frankly, the billing went through a labor arbitrage process where most of the billing human work is done overseas, mostly in India, because you had to be English speaking in order to talk with the people at the various payers to actually get the human stuff done. And again, there was major problems with the training and the turnover. I mean, obviously, Indian people are just as smart, if not smarter, than people in America, but oftentimes they were undertrained and they had high turnover. So the people themselves doing the work were not effective. And so the fact that we have this technology now, we're in a golden age of improving that process, which is great.
Well, love this topic because when I didn't come from the world of healthcare. I came from the world of logistics, retail, supply chain. And as much as everybody complains about healthcare and says, oh, healthcare is very complicated, and there's all this regulation, the all the things that we've been talking about, so first of all, the fact that the HIPAA standard, administrative simplification, exists, and all the payers, all the carriers, are forced to use the same schema for the claim and the eligibility check and things, is a huge simplification that doesn't exist in the world of retail and logistics. Now, yes, like the schema for a claim is a 650-page PDF, but at least it explains everything that's allowed and not allowed. And then you have CPT codes and ICD-10 codes, which are long-running, relatively stable, comprehensive, checks, basically, of or definitions of what can be done. And then you have
Mhm.
things like NCCI edits, which are claims validations, and Medicare NCD and LCD edits of all these different, national coverage determination, local coverage determination, things that can be done. And uh, and so there's a lot of things that can be deterministically checked. That, in other words, deterministically generally does not require human judgment. It means that if you
Right.
run this through an algorithm 100 times, you're going to get the same answer 100 times. You want to check, is a CPT code valid? Well, you run that check 100 times, and 99 times it says it's valid, and one time it says it's not valid.
Right.
Do you have a sense of how much of what we're talking about here is, is it deterministic, in which case it's just that nobody has invested enough to
Right.
codify all these rules versus the bucket of probabilistic things that require human judgment and therefore have these problems of labor turnover and burnout and potentially can be solved by AI.
Yeah, so I would say greater than 90% of it is deterministic. So, I
Wow.
mean, it's
Yeah.
just it's a fantastic, opportunity. Now, the one thing that I will add is that let's say you actually went through all of the efficiencies, that's gonna really help both the, the providers, the docs and the hospitals and the ASCs, and frankly, it's gonna help the insurance carriers would not have to, at the end of the day, being able to pull cost out of the system is gonna mean that, like, people are gonna, like, n lose their jobs, which I just wanna tell you, as a physician, if healthcare can be less expensive so that more people can get access to care, and that requires people to have to get a different job, I am okay with that, right? We do not ride around on horses and wagons anymore. I'm sure horses and wagons employed a lot of people, but we don't do that anymore, right? So are we going to stay on horses and wagons for the sake of employing people? No. Right? Are we gonna keep healthcare costs incredibly expensive and prohibit people from getting the care that they need just so we can employ people? As a doctor, my answer to that is absolutely not. Okay, so make no bones about kind of where other people have different positions, right? Politicians who need to have jobs might have different positions. I do not have a different position on that. But the insurance carrier, let's say all that is done and you've dramatically made it more efficient for the billing. Keep in mind, the payers hold the money. The doctors and the hospitals do not. They're trying to get the money. And especially for the insurance carriers, the model of insurance is to make money off of something that is called the float. And the float is the time between receiving premium, whether it's from a company or from the government, and then paying out a claim. And that time can be hundreds of millions or billions of dollars of quote unquote unpaid claims. And the insurance company invests that money and makes a return off the float. That's part of how Warren Buffett got so rich. It's how life insurance companies work. So just know that even if all of this AI stuff happens, the insurance company could be like, well, we just want our float. So we're just not gonna, like, everything's fine. Like, there's no problem, but we're just gonna wait. Just know that that dynamic still exists.
Sure. Well, you know, there's things that could be done there where, to your point, 90% of the problems are deterministically um, uh, solvable. And if you do solve those problems, and it gives you a much greater confidence whether a claim is going to be paid or not. And if you have that confidence, even if the insurance company is going to sit on that for 30, 60 days, whatever it might be, you can do financing. So you could do factoring, you can do, what they call revenue acceleration. If you have a high degree of confidence that those claims are eventually going to get paid, and there's plenty of
100%.
people who are working on this. To your point
Yep,
about the
100%.
jobs, I would say that it may be possible that the total number of employees involved or contractors involved go down, but that the total number in the United States may go up, because if you're able to replace a lot of this human labor that's been outsourced to lower cost countries with software and with more deterministic checks, you're left with kind of the more expert determinations being done, and those are often done in the United States.
And I mean, to your point, I mean, we need people also just in these clinical roles, right? So to the extent that we can, retrain people and have them more involved in these believe me, there's work to be done. I'm not saying that there's not work to be done. It's just different.
So we're coming up on our last few minutes here, and we got into a very valuable rabbit hole talking about how the claim is actually issued and the different dynamics there. Maybe you can wrap this up by just giving us the high level picture of the rest of the steps that happen in the system that we were talking about, and then we can close this out and hopefully have you back for another session, because I think there's just a lot more that we can cover.
Yeah, and Zach, thank you for having me, and thank you to all the listeners. I think that this is a very good, like, just appetizer for all the dynamics, because, like, literally what Zach and I have just covered is the tip of the iceberg. Like, we're just getting warmed up. And I'll just kind of like give you like a preview of like what the next thing is. So everything that we just described in no way impacts the what is referred to as the patient out-of-pocket cost responsibility. So of all this, allowed amount stuff, some of that is actually then borne by the patient, and it could be borne in their deductible. They got to pay deductible amount. They've got to pay a co-insurance amount. They might have to pay a copay amount. And then how that is calculated and then how that is then billed and then paid for by the patient adds yet a completely other level of complexity to what the docs and the hospitals and the insurance carriers, the employers, and the patients themselves have to navigate. So it's great, Zach, that you are like bringing up this topic. We need as many smart, motivated people as possible, improving companies or starting new companies to help address this issue. I'm very thankful that you started Stedi. I'm thankful for all the people that work at Stedi, and all the people that work in this sector of the industry are hugely important. So just know that I'm like 100% like behind like what you're doing. So keep it up.
Well, very much appreciate that. And what's not always obvious is the hundreds and hundreds and hundreds of customers that we have who are building on top of our rails. And we look at the things that our customers are building and we're amazed. It's across clinical, across administrative, billing, front end RCM, back end RCM, things on the payer side. There's just a tremendous ecosystem that's becoming possible because of programmatic access through APIs and a lot of deterministic logic that we're providing and able to provide more and more over time. And I think the future is very bright. Well, let's close with the question that we always ask, which is that if you could change one single thing about revenue cycle management that does not require a fundamental reworking of the system, for example, going to single payer, what would that be?
That does not require going to single payer
or,
is
or doesn't
I would
require a fundamental reworking of the system at all. Just something.
yeah.
If there was there's an easy button to press.
Yeah, I would say that um it's very important for everybody that works in the industry to be an autodidact. So what is something that you can do like today, right? Nothing theoretical, but what is something that you can do today? Is that healthcare is largely not in formal instructional settings. It's not in academia. The only way you're really going to know this is if you yourself go out and learn how to do this. So you've got the reins. There are tons of resources, obviously now on YouTube, or you can just ask ChatGPT or any other LLM, right? So just know that you yourself are responsible for educating yourself about this. No one's going to spoon feed you. And so if people started just taking more of an active stance in their own education around these matters, then I think we'd all be better off.
Well, I think the best way to do that is to find the AHealthcareZ YouTube channel and start working your way through the videos. So what we're going to do is include in our show notes a link to the videos that touch on all the different topics that you and I touched on today, and people who want to be autodidacts can go through and learn these things for themselves. Dr. Bricker, thanks so much for coming on the show, and it was a pleasure to have you.
Thanks so much, Zach. Appreciate it.